Good evening, everyone. Hey, we're gonna invite Dr. Matthew Fien. Let me send the invite to him.
You made it.
Hey, Matt, how are you?
Good. How you doing?
Good.
It's great to see you.
Oh, wow, we've already got 21 people on like 30 seconds into this. This is
I have a big family.
I think we're breaking records here. I don't know. I think everyone at Osteogenics maybe is working late. I don't. I
Yeah,
don't.
that's
I don't know.
probably it. That makes more sense.
That's awesome. Hey, well, I think everyone joining already knows you, but we're here tonight with Dr. Matthew Fien, periodontist, works in the Florida area. Maybe you could tell us a little bit, what have you been up to lately?
Well, timely question. Actually, after practicing for about 14 years down here, working for a couple of offices as an associate, I just opened up my own office. So
Oh, wow.
that was about 6 months ago. So we've been busier than ever, just trying to manage the practice and get everything, all the ducks in order. So it's been a crazy couple of months, but it's going great. Thank you.
That's awesome. Congrats. I knew that was something that you were considering. I didn't know that, I guess it's been too long since we last spoke because I didn't know that you'd already got that done. So are you solo practice or is
Yeah,
it
I mean,
partnership?
I've really been keeping it a secret. I sort of like wanted to get all, everything lined up and have the office running smoothly and everything. So we did sort of a soft open, I like to call it. But now we're sort of ramping up. I'm there much more often. Yeah, and we're busy. We're doing surgeries, so it's been amazing.
That, that's really cool. So is it in where exactly is
So
which city?
East Fort Lauderdale. So I live in a suburb of Fort Lauderdale called Plantation. And I just head east, to US 1 basically, which is very close to, the ocean, in a very, very populated area out there, East Fort
Yeah.
Lauderdale. So commercial and US 1
Yeah.
is the cross streets.
Awesome. Well, so are you still with your practice? Or I know you're doing a lot with continuing education. I know you got a couple things coming up. Are you going to be able to do as much education, or is it
Yeah,
how do you that
the
balance?
goal is always to sort of find the balance. And that was one of the reasons why I wanted a home base, so I could sort of be a little bit pickier about, the types of cases I do, have more time to service, the general dentists that refer to me. But yeah, we got a lot of things coming up. It comes in waves with the continuing education, and I feel like this time of year is where it gets really crazy for us. So March and April will be 2 fun months, and then I'll try to take a little break and be with the family over the summer. So yeah, I don't have any plans to slow down, but of course, life gets in the way. So we'll see what happens.
Awesome. I know you've got a course coming up. You've got two things in April. One is with osteogenics, and then one is with Get Your GBR On, right?
Yeah, yeah. I got a busy about month and a half. So I'll be in Utah for a great course. That's March 9th and 11th. March 9th through 11th, and then I'll be at the AO with my partner in crime, Israel Putterman. We have a hands-on course that's sold out already. That'll be fun to see everybody. And then I'm excited for our osteogenics course together. We're going to do something in actually my neighborhood. It's conveniently very close to where I live. So we're going to be doing a day and a half complex socket grafting course. So we're going to be covering a lot of the material selection, of course, soft tissue management, a lot of decision making. So that'll be a great course. That's April 14th and 15th. And then very excited for the first time, we're going to be doing our own guided bone regeneration course. We like to call it Get Your GBR On in Vegas for the first time the following
Okay.
week. So that's a 2-day course, and we're doing live surgery. So for those of you on the West Coast, that's a great opportunity. East Coast, yeah, swing by my neighborhood. I'll take you guys to all my local spots, show you guys around.
So for live surgery in Vegas, you're treating a patient in Vegas,
So
or you're somehow
we
broadcasting?
teamed up with a great friend of ours, Dr. Curry Levitt. So
Okay,
he
yeah,
has
sure.
an incredible institute. I've actually taken some courses there, learned from him some full arch courses. And so we're going to be over there. Dr. Putterman and I are going to be doing our normal course. We're going to be showing some more advanced cases. And then we're going to have Dr. Curry do some live surgery. So that's going to be really fun for us to be kind of poking him in the back and finding out, let's see if he can handle the pressure.
Yeah, that sounds like fun. So in Fort Lauderdale, so have you done a course in your own backyard before?
I'm kind of I'm a homebody. So yeah, I kind of tricked Israel into doing some courses in my backyard. But you know what? The traffic down here is crazy these days. The further east you go, it's a little nuts. So yeah, we've done a couple courses at the same location actually, but it's a great location, great hotel, big rooms, nice and spacious. So yeah, we're excited about that, but it won't be my first time at that actual location, that venue, coincidentally.
So so everyone gets to come by and drink your bourbon after the first day of the course, or what's the?
They can come by and drink my scotch. Absolutely. No, I don't drink bourbon. Sorry. Israel's the bourbon guy. Okay. I go with scotch, but yes, I'll definitely stock up and make sure we have enough for everybody.
Do people graduate from bourbon to scotch? Is that the pathway, or can you skip straight to scotch?
It's always been too sweet for me.
Yeah.
I don't know. I go straight to, it's so easy. Mac 12, call it a day.
Okay.
That's all I need. I'm a simple guy.
All right, so jumping into some of the more clinical, and if anyone has questions, please send it. You can do it in the comments, and we may catch it that way, or there's a question button, at least on my screen in the bottom right-hand corner. If you put it there, I'll see it, and we'll try to get your questions answered. So we're gonna go about 20 minutes worth of more technical questions here. So, we talked about your course, April 14th, 15th, Fort Lauderdale, that we're sort of partnering with you on that. It's hard in soft tissue grafting or treatment of complicated socket defects. So let's just talk about sockets for a second. I know that, kind of how we got to know you is you use our dense PTFE, our Cytoplast TXT200 membrane for ridge preservation. So maybe start off with, why do you use that? When do you like to use it? And then also what makes a socket more complicated, and how do you treat it differently?
Sure. I guess I'll start here. For me, there's two factors, when we're treating these patients that come in that need teeth extracted, right? It's the carpentry aspect of it. So knowing the skills, having the hand skills, knowing, the protocol or procedures that we have to follow. And then I think sometimes the hardest part is actually that decision-making, on what materials to use, when to flap things open, when you can avoid flapping things, because of course, we see these cases from years ago where we tried to open everything, right? We were kind of forced into thinking that, hey, we need to get access, we need to open things. Obviously, when you do that, you cut the blood supply to the periosteum, you're losing papilla. So really, in my private practice on a day-to-day basis, I'm trying to do things as minimally invasive as possible. So if I have a good tunneling spoon and I can extract the tooth and have, most of the walls intact, if a buccal plate's missing, but I have nice tissue, I don't want to flap things open. I want to use a membrane that I can sort of tuck in. So I'll either use, a stiff resorbable membrane, or if possible, using that dense PTFE membrane. Very easy handling. I like the singles. I don't like cutting. If I'm going to do that, I like to, order that pack of singles. I'll slip that in, tuck that into that, buccal defect, and use that as a wall. And I'll pack my bone graft into that, particular graft into that. And it's just a simple procedure. Most of these cases we're using, long-lasting resorbable sutures. When I'm using collagen with PTFE, I'm still using usually 3/0 PTFE, maybe like a crisscross or a horizontal mattress. But yeah, I think what I've learned in my own cases is, sometimes we get ourselves into trouble by opening things.
Yeah.
And so we have materials that we can use that avoids opening it. That's what I'll do. And really the main advantage of that is we're actually growing soft tissue. We're not moving the epigastrial junction. We're not forcing ourselves to have to perform a soft tissue graft or soft tissue manipulation later on. So it's a win-win for everybody.
Gotcha. So then what if it's complicated? Is that complicated because it's missing the buccal wall? Is it thin tissue biotype? Is it papilla issue? What makes to
me what makes a case really complicated is obviously a large infection, a large defect, but more importantly, it's whether or not the defect's within the housing of the bone. And that a lot of the time comes down to patient anatomy. I can look at cases where we were a little bit um, we sort of thought to ourselves, well, why don't we go ahead and leave it closed, because that's obviously minimally invasive. Patients don't have as much pain. We try to take a shortcut, and then you go back and take a CT scan later on, and you say, great, I filled the socket, but the width of the socket was so narrow to begin with that I still have to go back later on.
Yeah.
So trying to kind of figure that out from the beginning, like I said, is the hard part. I think the key to tissue quality, like you said, muscle involvement, frenum pull, things like that really are the cases where I look back and say, maybe I should have thought of this differently. Because there are times when we don't take out healthy teeth. The teeth that we're taking out are teeth that have usually large infections.
Yeah.
In a lot of cases, at least the ones that get referred to me. So when you start degranulating and you realize that, hey, I can't even be certain that I can degranulate from within this socket, then we start thinking about how to augment, maybe with a flap, right? But of course, once you start doing that, now you have opened up a whole nother host of decisions that you have to now address. Where do I put my incisions? Do I put vertical incisions? Do I obtain primary closure? And a lot of that has to do with, patient anatomy and, the size of the defect that you're treating.
So in the workshop, are there? I asked this sincerely because I'm not sure what the answer is. Are there pig jaws, or is it models, or what's the hands-on component?
So I always like to do a combination. I mean, for me, the day one is a great day for me to kind of give my thought process on the types of choices that we have to make, like we're talking about now. About here, like that decision making, but then I do like to do some complex sockets on models. So we'll be using some models the first day. Also, that's really helpful to get used to using the materials, the different biomaterial options that we have, and we'll have some collagen membranes too. Z matrix, comes into play there too for large span defects where I'm actually performing more ridge augmentation at the time of tooth extraction. And then day two is going to be pig jaws. And really the benefit of that is, we'll be extracting teeth. We'll talk about incision design. We'll talk about how to release soft tissue when we need to. But again, for sockets, a lot of the time we're better off not manipulating the soft tissue from the start. But we'll practice it both ways.
Okay. You mentioned, a lot of times these teeth are, they often come with a significant infection. So I always like to ask this question because I love to hear the different answers. So grafting into an infected site, do it, don't do it. If you do it, like what's the criteria there? How do you treat it? Are you using antibiotics?
Yeah.
Do you mix antibiotics with your bone graft? Like how do you handle those cases?
I kind of answer that in reverse. I mean, I never mix antibiotics with my bone graft. I've never done it. I was just never trained to do it. I know a lot of people do mix like metronidazole with it. To me, I've had great results without doing that. With that said, I am pretty picky about when I will graft. So for instance, I have to be 100% sure that I'm degranulating the socket properly. Maybe if I'm close to the inferior alveolar nerve, or if I'm close to the sinus and I'm degranulating and I don't want to break through, then there's nothing wrong with extracting the tooth, letting it heal, and knowing, you might have to go back later and do a proper GBR. But obviously, guys like Daniel Boozer, who's one of my, my favorite clinicians of all time, does that routinely. He says, let's let it heal for 6 to 8 weeks, come back, and now we have great tissue to work with. And usually at that point, you can go ahead and place your implant and graft alongside that. So, you end up catching up, which there's a lot of great evidence. Probably no one has more evidence than his group, on doing that. So I think that's a great option, especially if, we're not sure about the quality of the bone at the time of tooth extraction. I'll say the majority of cases, if I feel that I can comfortably degranulate, then I will go ahead and graft. I do put all of these patients on antibiotics before surgery. Right. So, which is a tough one because a lot of times you'll see patients for consults that maybe have urgent situations, emergencies. In those cases, I'll at least try to get them started on antibiotics, an hour beforehand, so we can still do same day dentistry. What's your separation? A little bit of a different story. I'm definitely a little bit less aggressive in those cases because a lot of times the tissue is just so friable. And that the second you start trying to even put stabilization sutures in, not periosteal lighting sutures, but just sutures that help to keep your membrane from coming out, just over the top of the socket. Even doing that can sometimes be very tricky when the tissue is so friable.
Your antibiotic protocol, I just know I've sat in a lot of courses, and when the antibiotic comes up, everyone's like, hey, what antibiotic? How many days? Like, can you just give us a real
Yeah,
quick,
honestly,
quick?
I think we overthink this, but I think there is a correct answer. I mean, it's very simple, and I got turned on to this a long time ago. When I was in training, one of my mentors, Dr. Garfinkel, used to always quote Barry Wagenberg's study from the early 2000s. He looked at 3,000 implants, and there was a 3 times greater risk in implant failure complications in patients allergic to penicillin. And, to me, that tells me very strongly that penicillin allergy patients, or patients at least who think they have penicillin allergy, I should say, they're not taking antibiotics that actually are helpful. So clindamycin is not helping against the staph and the strep and the types of bacteria that are really, in the oral cavity. So I want them on amoxicillin if I can.
Okay.
Start them on that, about 24 hours before surgery at least, okay? Or loading dose an hour before.
Okay.
If they're
Perfect.
allergic to penicillin, it's tough, and I think a lot of the other lit is finally caught up to what Barry Wagenberg talked about 20 years ago. Clindamycin now is not indicated. If I'm correct, I think Barry Wagenberg actually recommends Z-Pak, 2 rounds of azithromycin. A lot of us have problems with that because azithromycin is really bacteriostatic, but it seems to work well for me. My new go-to was product of, again, Israel Putterman just teaching me his ways and in prescribing Omnicef. And I haven't had any problems with that yet. So that's
Okay.
pretty much my go-to now for patients that claim they're allergic.
Uh-huh.
My best piece of advice is send your patients for allergy testing, especially the really complex ones. 10% of people that think they're allergic to penicillin are actually allergic. So when you start sending these patients for allergy testing, it turns out that most of them actually can take penicillin.
And then you prefer a type of penicillin.
Amoxicillin, yeah,
Yeah.
every time.
Yeah.
It's just so simple.
Got
Most patients do pretty well with it.
Okay. Yeah, I like that. So you talked about enriched preservation. Sometimes it actually winds up being a little bit of a GBR also in some of these
Mhm.
cases where, the defect is not a contained defect. I know from following your Instagram account, you post some beautiful cases. One thing that you do that sort of, I noted like you do, like you're pretty creative. Like you try things, you look for new ways to solve problems.
Mhm.
One thing is I've seen, and correct me if the technical part I'm getting wrong, but use some sort of like anchoring screws sometimes in the sort of more apical part of the
Mhm.
alveolar ridge for then using sutures for fixation.
Yeah.
Can you walk us through like do you have a name for that technique and what do you
I do actually. So listen, for me, when I was learning, again, my mentor, that same mentor, he would say the carpentry is the easy part, right?
Mhm.
But you have to learn biology, you have to learn the decision making. And once you do that, I've always felt that, because it's an art, right? There's going to be people that have preferences in the way they do things, right? And there were certain things that, for me earlier in my career, having to carry around the tacking kit and a screw kit was a little bit troublesome, and using them was even more so. Patients hated the banging and the tacking.
Yeah.
So, I was always trying to find ways that I could get predictable results without necessarily, going to hardware. Now that I've gotten more experience, sure, I love the sausage technique, it's that Urbans technique. And because I was doing that so much, I have gotten much more acquainted with using screws and tacks over the years. And so, a lot of us do that periosteal suturing. So we'll bite the periosteum. The one
Mhm.
thing that I found though, in certain cases, especially maybe in the posterior mandible, not only are you working near the mental foramen, so you're a little bit worried about necessarily perforating into that space. Even if you have a CT scan, it's hard to know exactly where that the canal is along the length of the mandible. And so I thought to myself, when you try to get primary closure, you pull for primary closure after you get your graft stabilized. Sometimes I would find that the stabilizing sutures would lose a little bit of tension, right?
Okay.
Because even though you've made a periosteal release and you're biting very far apical,
Ah,
you're inherently the flap still has a communication with the
yeah.
periosteum, right? So I would see those sutures lose a little bit of tension. And so I thought to myself, well, I have the screw kits now. I'm always ready. I never make a decision before surgery. I don't know if that's the right thing to do or the wrong thing to do. I always feel like maybe I want to go a certain way, but I never want to close out, the ability to change my mind in the middle of surgery when I actually see what the defect looks like.
Yeah.
when I see how easy the patient is to work on, you know, how much access I actually have. And sometimes you want to change the plan. So in this case, I actually had, you know, a screw kit out. It was your screw kit. It was the Profix kit. It was 3mm Profix screws. And everybody knows, you know, it's very difficult just getting used to stabilizing a membrane with the screws, because the membrane tends to want to turn on you. Works great for, you know, DPTFE, titanium reinforced membranes, but for collagen membranes, it's not so simple.
Sure.
But it's very easy to put a 3mm screw into the bone. So I thought, you know, rather than biting the apical periosteum, I can put this screw 3mm in. I saw in the CT scan that I had 3mm of buccal bone, you know, from the canal. So I knew that I wasn't going to have any issues with, you know, hitting any vital structures. So you can just put a little screw in, and then you can, rather than biting the periosteum, you're just wrapping you can wrap the suture around that, that little screw, almost like think of it like a noré at a boatyard. I'm not a big boater. I get seasick very easy, but one of my friends said, oh, it looks like a noré. So now I always say that. But yeah, so I call it the screw roast. It's kind of a joke. I think Israel helped me come up with that name. We have we're trying to get it published. To be honest with you, you know, it's got rejected a couple of times because they didn't have enough cases, and then we sent them more cases, and we're waiting to hear back on them. So hopefully that'll be out soon in one of the journals.
Yeah, I think, yeah. I mean, the cases turn out beautifully, so I like it. So talking about sutures, I know that you use PTFE suture. You also use our glycolon suture. You may use some other sutures. Like, what sutures do you like when? Which one are you using with the, what do you call it, the screw roast?
The screw roast, you know, for all of my rib roast or screw roast cases, you know, I started off using chromic gut. And chromic gut, you know, is something that's periodontist. You know, after you do a surgical extraction, if you're not grafting it, sure, you use chromic gut. So it was simple, it was easy, and it's what I had lying around. But the problem is, obviously, anyone that uses chromic gut, they know it says 7 to 14 days, but man, those things are gone easily at 6-7 days every time. I almost like the fact that it's so predictable, because patients, you know, they ask you when they're going to come out, and you say 7 days. If you see them at 1 week and they're still there, you say 1 more day, they'll be out. But I was just worried for these ridge augmentation cases, you really need more stability. And I don't want to use a non-resorbable, because, you know, you leave that in for 2 weeks and everybody knows, you know, that's great for final closure, and you do a horizontal mattress with it. But how many times do you go back and you see, because the PTFE is so biocompatible, it's hard to remove, right? And so again, Israel is like one of my mentors. He turned me on to glycolon maybe 4 or 5 years ago. So it's polyglycoprone. You know, it comes dyed, so it's easy to see, which is key. Much easier to see than the chromic gut, and much easier to see than a lot of other sutures. And the handling is super nice. So it's very strong. And actually, in our courses, what I often do is I'll bite the apical periosteum and just take the glycolon and just start pulling on it, just to show people how strong it is. Because the last thing you want to do, if you're trying to stabilize a membrane with sutures, the last thing you want to do is you know, be midway through stabilizing your suture, go to tie your knot or something, and have the suture break, right? Yeah. And it's just really frustrating.
With chromic gut, do you see, because, I mean, we often are trying to position the glycolon against chromic gut. We like it. You know, glycolon is a faster resorbing suture than PGA, and it's a monofilament, whereas PGA is a multifilament. So we like it for those reasons, but also it's a more like consistent diameter and a consistently strong. But there's
not one category where chromic gut is more beneficial. So at this point, I haven't ordered chromic gut in about 3 years, right? Because I'm using glycolon for everything. I'm using it for soft tissue grafting. The only time I'm not using it for soft tissue grafting, and I'm still using it, but I'm also in some cases using, you know, something that has a little bit of a longer, or, you know, a non-resorbable for large full arch soft tissue graft cases where it's just so important to maintain the tension for even longer than 2 weeks, right? But for the majority of cases, I'm just using that because, number one, like you said, there's absolutely no anti-inflammatory reaction. They don't build up plaque because it's monofilament. So very easy. And they're not bothersome to patients. They're not as, you know, like glycolon is very, like nylon will be very, very stiff. Patients will complain about it poking. I just don't get that with the glycolon. And then to top it off, it's very easy to handle, you know. The handling is easy. That's what I want. Chromic gut's very difficult to handle, even after doing it for many years. Sometimes you open up the package, it's very dry or very sticky from the alcohol.
What about about knot tying? Is it how does it compare? Like just other sutures? Is it being a monofilament? Sometimes monofilaments can be a little harder to knot because you don't have
Mhm.
that friction like you do from a
Yeah.
multifilament. Do you see
No, I
issues?
mean it holds down really nicely. I know you guys have talked about the study of, typically we will do two forward, one back, one forward,
Mhm.
to do like a square knot. But for the glycoline, I know there's some studies showing the increased ability to resist that tension if you do two forward, one forward, one back. So it's one of those situations where, I think there's always improvements that you can do. That's why I love the courses, because we actually done that in the courses. We kind of played with it, and we've had people walk around the room and, take a perio probe and try to pull the sutures out, based on, whether or not how they tied it. To me, as long as you visualize, if you have good lighting and you have loops on, you can see whether or not the knot is down. And if you've squared the knot, and if the knot is squared and it's down, it's not going anywhere.
Okay, awesome. Hey, we got maybe a couple minutes left. I want to ask you two more questions, and this question is a really loaded one, but maybe we could keep it short. Is periimplantitis?
Mm.
Uh, when do you extract versus save? And when you save, what's your protocol?
That is the ultimate question. So, the easy answer is if it's my implant, I'm going to save it. If it's someone else's, I'm going to take it out. I'll just throw that out there. And honestly, that does come into play a little bit. We do think about that, right? Because if I'm going to start treating somebody and I have to start charging them, money to do a procedure that's not all that predictable, it's not something that I really want to get married to. So that becomes a big part of it. One of the things that I try to do is really talk to patients a lot before these cases, before we make a decision. I've had cases where we were planning on taking things out, and I've said, let me try to hit it with my laser and see what happens. And I've done really, really well. And so it's just like a tooth. Once you take it out, you can't put it back. Okay. In terms of protocols, it's very rare for me to try to graft around an implant, just because in my mind, the implant's in the mouth. It's despite us, burnishing it with, bleach or whatever we want to do there, using a titanium brush. I just don't believe that we could really clean the surface of the implant in order to be able to regenerate bone. So for me, if it's a case that's non-aesthetic and I can perform a classic perio procedure where I can open it up, clean it out, maybe create some positive architecture, reduce the depth of the defects, I'll do that. I'll still clean the implant, and I'll even be more prone to soft tissue graft those, right, to make the tissue thicker and to make the tissue more keratinized and more defensive in the future, rather than grafting it. Do I ever? Sure. There are cases, maybe crater defects, where I can really get in there. I get good access. A lot of times for me, it depends on whether or not the crown, the restoration is on, and if it's a screw retained crown, then it's easy for me to remove. And if I can get in there and actually put eyes on the defect, I have much more confidence that, maybe grafting it'll hold up.
Yeah.
But I always make the analogy with patients, even with teeth, if the tooth is not loose, right? First of all, if an implant's loose, it's coming out, right? There's no discussion. Once we have any degree of mobility on an implant, it's coming out, right? And so if an implant's not loose, then technically we don't need more bone. It still has some osseointegration.
Yeah.
So I'm not so worried about the bone. I'm worried about the infection. So it becomes a disease control issue. And I think, a lot of times in these cases, it's combinations of treatments, and it can't be necessarily done in one visit. So maybe hit it with a laser. I had one recently that was referred to me from an incredible doctor in Pennsylvania, but his patient's a snowbird. He came down here, and we hit it with the laser, and it's looking great at about 2-3 months, and there was just no soft tissue quality to work with. So before we put the crowns back, I talked to the patient and we discussed doing a pregingival graft. And I love that because, and I explained this to the patient, look, down the road, 3-4 years, I don't know if that implant's going to get infected again. So if it does, at least we have this thick tissue. And if we do have to take the implant out, at least the tissue quality is much better. It's kind of setting up the stage, or at least we're moving in the right direction.
Gotcha. Awesome. So we're out of time. I feel like this could probably go for easily for another
Yeah,
30
let's
minutes.
do it again next week.
so two courses coming up. You got the one in Vegas that includes the live surgery. The dates on that are?
Yeah, so we got live surgery in Vegas. Come hang out with me and Dr. Curry Levitt, who's amazing. He's got an amazing facility. And then obviously the guy who needs no introduction, Dr. Israel Putterman.
Yep.
As you see, we've kind of like learned from each other
Yep.
over the years. So, I always kind of joke that I do, things the way he used to do it and vice versa. But we're going to be doing a 2-day intense course. That's going to be basically GBR. So it's a general title because we're really going to be covering a lot of different, treatment options that you have, soft tissue management, stabilization of membranes, different membrane choices. And then the other course we talked about was the week before, the osteogenics course, 14th
Yep.
and 15th in Fort Lauderdale. So I think it's good. We got options for people on the East Coast and options for people on the West Coast. Just worked out that way.
Awesome. So I know if people want to register or get more information on the osteogenics one, I know that you go to our website. Also, the link is in our bio.
Mm-hmm.
And want to learn more about the Get Your GBR On course with Dr. Levitt and Dr. Putterman,
Mm-hmm.
where do they go to get that information?
So probably the best place to go is just on my main page. Just hit the link tree, and you get more information on
Endodontics.
different courses. We're super excited, Israel and I. We just hired a full-time employee. That's she's just been amazing at setting up, our future courses. So we got a lot of new things coming out in 2023 and 2024. So if you haven't followed Surgical Influence, you can also follow Surgical Influence for updates on other events.
Yeah, everyone go follow Surgical Influence. Well, hey, man, I really appreciate your time. And I'm really excited for the course we're doing April 14th and 15th. Love working with you, as well as Dr. Putterman and the rest of it's kind of like this network of doctors that you guys have. So appreciate you, and thanks for your time.
Thank you. Thanks for everybody that joined, and we'll see you all soon. Thank you.
All right, have a great night.
You too.
Bye.